Welcome to Dental XP Digital Dentistry. My name is Dr. Dean Vafiatis, and we'll be talking about anterior implant aesthetics in the digital world, the reality of how digital dentistry is done today in the anterior region. I'm a faculty professor at NYU for the past 23 years. We run the full mouth rehabilitation program at the NYU Clinic at NYU every Friday. And we do have a 4-day course also that we are offering in October and in April. So you can go online or email me to information for that. The reality of digital dentistry. We've been talking about this for about a year. We've had a long year run discussing anterior and posterior and full arch digital dentistry. I've been involved in digital dentistry since 2005, so for 12 years we've been scanning, milling, and making anterior teeth and posterior teeth, and I'll share with you some of the experiences, some of the complications that we've had, and where we are today in 2017. Many of the cases that patient treatments that you're going to see could not have been done without these great sponsors who believed in my vision of getting things done easily in an expedient fashion with the great scanners and the great technology. So a lot of these laboratories have been very efficient in helping us out to treat our patients in the proper manner. So I want to thank all these companies and the individuals as part of the family of digital dentistry for the last 8 years. So we just finished our digital tour. We started with 28 cities. We ended up with 42 cities around the world teaching the digital technology. Many study groups, annual meetings and sessions. So it's been a wonderful year returning back to New York and to stop traveling. Can't travel anymore. It's been tough. Our office is in Manhattan. We invite you. We have full specialty practice, prosthodontics and periodontics, and an office with a laboratory as well. We do a lot of patient programs, a lot of hands-on teaching, a lot of one-on-one education. If you're interested, email me at drdean17@gmail.com. Happy to help you in any way, or if you have any cases or to learn more about digital design. So let's start with digital technology for all restorative procedures, not just for single teeth, not just for posterior teeth, not just for digital smile design, but really for everything. That we can be able to take patients and analyze them in portions, ideal smiles, the implant planning software that's available, the quality control design that really lies for the patient, that lies for the actual dentist who becomes the quality control person for each of these cases. How to analyze our occlusion. Without occlusion analysis, our restorations are going to fail if you don't have proper guidance and proper canine protection of all of our anterior cases, especially our full arch cases. And how we do our digital impressions together with photography and videography to make the restorations really work well. Why did we go digital? We started digital 12 years ago. We first bought a ferric scanner. Then we bought a lava scanner. Then we bought a E4D scanning mill. And then we got our Trios. And we currently have 5 scanners in the office. Well, the first main reason is to give a better patient experience. Second reason is having more options with restorations and saving hours and hours of time for the assistant, for the doctor, for the front desk. And taking your practice to another level through digital enhances the patient experience and the dental experience for the dentist. It just makes things a lot easier for us. We find it to be a valuable item. If you ask me how many restorations out of 100 restorations are done digitally, I would tell you about 75 to 78% are done digitally. There's still some PVS impressions that we take on certain situations with digital that can't scan through blood if there's not a retraction, so we'll still have to take a PVS impression. One of the things I like to talk about is that the digital technology does not replace fundamental prosthodontic principles without proper understanding of the occlusion, the functional aesthetic relationship. Without understanding basic dental concepts, it's very hard to use dental software and digital software. Otherwise, we're just wasting hours and hours of software development. So if you give me a very knowledgeable dentist and I show them digital, they will very much benefit in the digital world. If if you give me a dentist that understands digital technology but doesn't understand basic principles, it's really a waste of time. So the more knowledge we have as individuals in dentistry, the easier we can use these digital components. So let's talk about the patient experience for a second. Mobile app check-in is a must in your offices. Digital radiography, obviously most people have that. The digital preoperative scan. So we'll take pre-op scans of every new patient. We'll take a CBCT scan for every patient who needs implants or has any impaction molars or anything that we can't see with regular radiographs. We'll take photographs via DSD simplified protocol for the basic photos for DSD design. So we have all those photographs. And then we present the patient with what we feel is the best options for them. Sometimes they can afford it, sometimes they can't afford it, but we will always present them with the facts of what they have in a monitor digital platform, showing them how their implants are going to be designed, show them how their smile is going to be designed. So everything's done in a digital platform, and that really makes the patient experience very different than what they're used to. So right now, our fastest scanners right now is the Trios. Our TrueDepth is also very quick. Our Plant scan is ready. These are the top three that I'm using right now. Still use the CEREC here and there. Again, the scanners are very good right now. They're all compatible in terms of any kind of software. The CEREC still remains, the Sirona still remains a closed system, and I'll talk about systems in a little bit. So the hardware is the actual acquisition units replacing the PDS impressions. That's all they're doing, replacing the PDS impressions. They don't do any miracle, things that people expect them to do. They're just taking the digital impression. Orthodontics also is very good. The Anterior is also a very good option, so I don't want to say that we're just showing the ones that we use. All digital scanners right now, 2017, are very accurate. The problem and some of the inaccuracies has to do with the software system. So if the information is gathered by the scanner and sent to your laboratory, and your laboratory does not have the proper software, then the images, as you would expect a photograph that has pixelization, the higher the pixelization of the photograph, the better accuracy the photograph can be printed. If you're taking your photographs and your digital scans with a low pixelation, or the software is a low pixelation, then the accuracy is going to be diminished. So when people say the scanners are not accurate, it's absolutely not true. If you say the software is not the proper software, then you're going to get images that are not quality images, and therefore the printing technology is also going to change. So the disadvantages of digital technology is not the scanner, it's the software and then the milling hardware. What kind of milling machines does your laboratory have? Does it have a $50,000 milling machine, or does it have a $2 million milling machine? Obviously, the more expensive and the more elaborate and the more sophisticated the printing technology is, the better your systems and the better your restorations are going to come out. So if you send a beautiful scan that you've taken of your beautiful restoration to a laboratory that has an inexpensive printer, that has a 2-axis printer or very inexpensive software, you're not going to get the quality of margination that you would with a $2 million printer. So we've discovered that the best laboratories right now in 2017 are the ones that have invested millions of dollars in their printing technology that allows a single unit or a full arch or an implant restoration to really be fully milled in a digital platform that's accurate. So as an experience for a patient, this would be an analog office, this would be a digital office. So obviously, visually, it feels different, it's more efficient, it's ergonomic. There's companies right now like SurfCT that will take your office from a non-digital office to a digital office with a minimal, no downtime in your office, but just more physically changing things with a more digitally workflow, and the workflow is better. So our vision was to change the world of education in implant aesthetics and occlusion through a digital world. That was my vision 12 years ago, and I think we're slowly accomplishing that. From implants to aesthetics to occlusion, is using digital technology in every facet possible to be able to change the experience for the patient, the experience for the assistant, and of course make it easier for the dentist, because we're more inclined to evaluate our work dentally and get a better restoration without having to try and visit. The word try and visit to me is a waste of time. It's been a waste of time my whole life. and now we finally can see things before we print them, before we go to finish, and we can actually evaluate them. So digital dentistry for impressions for all types of restorations: onlays, inlays, implants, implant abutments, 3-unit bridges. We don't do a lot of removable, but there's definitely options for removable dentistry as well. I will go into the anterior workflow quickly, and then I will go into the anterior implant workflow, which is what the main topic is. But I want you to understand that we're using digital technology on a daily basis to create abutments, crowns, provisionals, temporaries, onlays, and implant abutments, and full arches. So also, I want to clarify that full arch impressions are a reality. We have over 120 full arches of teeth and implants. It's accurate if it's done in the correct way. It will be inaccurate if the systems are not in place. So I'm going to share all the systems with you so you understand the way we do it and how it works. So depending on which one you like, and which one you feel better with, and which one your hands work better with, I highly recommend the Trios and the TrueDef and the PlantScan. The Anterior is very good as well, but sit down, play with them, use them, try them, do a demonstration, go through the process for yourself. Don't take anybody's advice. It has to feel good in your hands. Try the full arch scanning, try the single unit scanning. If you like touch screen, if you like a laptop, if you like integration with a hands-free, whatever you like in terms of what you want, you write it out, go to the companies, go to the distributors, say, this is what I really want, and then have them show it to you, do a demonstration, and then you'll feel it for yourself, and then you start seeing how easy it is in terms of the acquisition. Typically, it takes 1 or 2 days of education for the staff and the doctor. Please don't have the education just for the doctor. Please have it for the assistants as well. I would say 50 to 60% of our scanning is done by the assistants. The final impressions are done by myself or the other doctors. So we need the assistants, auxiliaries to help us do the pre-scan. The pre-scans are very important. They save you a lot of time. So when you get the education, please have the whole staff involved. The system, just one system to show you, is the Trio system. And you can see here that the order is created. All the information is done beforehand. So when you're scanning and after you finish scanning, it's going to be ready to go to the laboratory. So you're choosing your laboratory. You're choosing your type of restoration. You're using the type of material, teeth. You're choosing all these information before even the patient arrives. It's all ready to go. So by the time the patient walks in, all you're doing is really scanning the prep or the abutment or anything like that. The assistants have done everything else. The CAD design is done in our virtual articulator on most of the good laboratories, and that's a very powerful tool. Occlusion, one of the biggest advantages of taking the vertical bite records, and then the milling product, and then the adding of the porcelain is the technical part, and then you can see the registration. So the workflow is very quick, it's very easy, and for all the different scanners, it basically works the same way. Key component, again, is the laboratory. Choosing the correct laboratory will make or break your cases in terms of the fit, function, the aesthetics, and all that. So choosing the right laboratory, and I'll show those over you. Single unit central, the most difficult tooth, is again very typical. To do the preparation, do the scan, choose the right color, scan in color. Most of the scanners are all in color now. Black and white doesn't really work anymore. I mean, it works, but it's not valuable. Very clean margins. This printer is a $2 million printer. It gets a perfect margin here, and the technician can make a beautiful crown. So the accuracy is there for our regular anterior protocols. We can get great results with beautiful margins, just as we did with our stone models, and insert that case in a patient that broke their old veneer. So again, it's the basic workflow for an anterior tooth. I wanted to just do that for you, show you some anterior cases just on teeth, and then we go to implants, you'll understand the concept. Dark teeth, scanned with the PlantScan, marginated by myself. You can choose to marginate every one of your cases. If you want to get crazy, you can choose to not margin any of them at all. That's up to you. We retract, we scan, we design it ourselves. If we want to do a one-day visit of scanning anteriors, or if you want to send it out, that's fine. You can work the digital workflow any way you want it, specific to your practice. If you have 5 doctors, it may be a different workflow. If you have 1 doctor, you may have a different workflow. If you have multiple users, you have different workflows. So each office has its own type of workflow, and you can choose it any way you want. And we basically just throw that tooth in a single unit. 1-day protocol. EMAX total patient time was 1.5 hours. Total time in the mouth for me was prepping the tooth scanning the tooth, designing the tooth. Total time for me was maybe 30 minutes, and then the insert was another 15 minutes. But everything else was done outside the operatory. I don't have to be in the operatory the whole hour and we get a nice result for us in the anterior. For multiple units, in terms of teeth, we're prepping the teeth, we're scanning them. We can't do these in one day. We're going to have to do them at least in a 2-day, 3-day, or 1-week protocol. But here's the key to it. Understanding the design features and looking at this as a quality control dentist, I'm looking at saying this is way too far outside. We can use it very quickly and redesign it, put it in the right position, send it to the laboratory, and they can go ahead and I can see myself and I can see how if I didn't prepare enough, it's in the cross section of the prep. You see over here I don't have enough clearance, I gotta either prep it more or add more bulk. So it gives us a lot of quality control. Quality control has to be from the dentist. It cannot be from anybody else, but you're in charge of the quality control. And once we make the copings, we do a pickup impression, and we delivered this restoration in a 3-visit protocol with EMAX units in less than a week. So all these things are possible because of the quickness and efficiency of digital technology. This is one of the laboratories we use, Rowe. It's from Cleveland. This is BJ from Rowe. Spent over $5 million on its laboratory. CAD Pro from Durham in New York. Doesn't matter where the lab is. The other one is Midwest Dental Labs in Florida. All those are very highly invested in their printing technology and can give you some great results. Over the last 6 years, we published our paper 6 years ago. That was 79 units. When we published it, we're over 250 anterior units done in the office or within a 2-day protocol, veneers and crowns. So technology is there, the accuracy is there. You can see the tissue health is very good. So all these are done by CAD/CAM. So in terms of digital technology, we always use the DSD protocol for our patient motivation. We want to show the patient what they can possibly look like with our motivational mock-up, and those are milled in position with a very soft plastic material, designed within 5 minutes, scanned and designed within 5 minutes, and then sent to the laboratory for printing. You can get these back within a week, sometimes faster than that. But again, this is our DSD motivational, and then the patient says, okay, and we start our treatment. So that would be our motivational wax-ups for any anteriors. We published this article in 2007 that basically said CAD/CAM technology for implant reduces chair time, saves patients a lot of visits, and the doctors in terms of time. So these were one of the beginning stages of using CAD/CAM technology. It was very expensive back in 2007. 10 years later, it's very inexpensive to do CAD/CAM abutments. But the reality is, what digital dentistry has done, and if you look at the way we scan our implant scan bodies, you see this on the right. That's a digital scan of a scan body of an implant. All the different implant companies today have what's called scan bodies. What that does is you take off the healing cap, you put on your scan body, and you go ahead and scan your implant. All the information is sent to the laboratory, whether it's single units, multiple units, anterior. But the key component to all of this, ladies and gentlemen, is the emergence profile, being able to dictate that, the tissue preservation of the tooth that was there. That's the key to digital dentistry, because it allows you to copy and paste information, tooth, roots, sizes, abutments, angles. It allows you to change that. And of course, using the CAD/CAM provisional, which is the article that we published, to enhance the tissue for final aesthetic result in the anterior. Let's go through the current protocol. For the protocol for the patient presentation is, if you look at the middle photograph, this photograph here, this is a combination of 3 files: the scan, the CT scan, and the laboratory workflow that has been created. So 3 different images have been overlaid to show the patient and the doctor the final result of these 2 units: intraoral scan, CT scan, and laboratory design scan. So those are all 3 files. This was not available 3 years ago. We call this merging of the files. Merging of the files, pre-surgical prosthetic planning, based on where the teeth are supposed to be, where the bone is, and where the angulation of these implants are going to be. This was done by Durham Dental Lab. So what did I do physically? I physically scanned the patient, took a CT scan, sent everything to the laboratory, and they gave me back this in 2 days. I like it, I approve it, and I send for a surgical guide. If you want to print the surgical guide yourself, that's another option. It's another investment. That's available. If you're doing a lot of implants and you want to print all your surgical guides, you can buy a printer, and that one, again, doesn't have to be very expensive, but it has to be accurate. In terms of anteriors, I want to clarify something. If you read these articles from Sadoun, Tarnow, Gunder, Salama, you're going to find that their position of their implant was placed at 3 millimeters above the CEJ. Not looking at the bone position, but looking at the CEJ position. Some of them are cement retained, some of them are screw retained. We approach our patients not based on cement or screw. We base our decision on where the bone is for that patient. You notice this patient is being treated for a screw retained restoration, and there's implants are coming out of the buccal plate. So forcing the issue of screw retention may not be the best option for each patient. This may be better off doing a cementable case because of where the bone is. So I want to clarify that we make our decision based on what the patient has, not putting everybody in a cement restoration or putting everybody in a screw retain restoration. We really want to customize it for the patient. But the key number that we discovered is right here, 4 millimeters below the CJ, and you'll see how the future papers after 2008 refer to the same thing. So we'd like to either make a stent with some teeth, take a surgical guide with it. We can evaluate this with the patient and show the patient where their bone is. Obviously, they need bone augmentation, otherwise they're not going to be any kind of, a lot of pink porcelain if we don't do any bone or tissue augmentation there. So by doing this, we know where the CEJ levels of the teeth are, and that really allows us to make the proper planning for the implant, and also plan for the surgical guide, and also plan for the provisional. So we use that information. We plan our implant position, we decide whether we're going to do screw or cement, and then we make our surgical guide. Just to show you how we merge the files, this is a pre-scan with a 3M iOS scanner. This is the CT scan sent to the laboratory with two files, the STL file, which is this, the DICOM file, which is this, and they're merged together. The laboratory makes the two teeth. You like it, you approve it, you say yes, mail me the surgical guide, and they mail you the surgical guide. So this is a daily practice, bread and butter. Scan, CT, scan the mouth, send to the lab, they give you a surgical guide. You want to print these, like I said, you can print them yourself. This becomes a third file. Now you have more of abutment and tooth, merging more than just the STL file. Now we're merging the crown. On the next photo, you're going to merge the crown and the abutment. So we're putting everything together now. And we are merging the STL file from the scan, the DICOM file from the CT scan, the crown, the abutment, and the implant. So we're putting all the files. Now this is 5 files merged together. Why? To show the patient where we're starting, where the bone is, where we're going to end up. It's a patient education. And believe it or not, it helps the staff, and it also helps you as a dentist to understand what kind of treatment you're going to provide. So this merging of the files today literally takes me 3 minutes. 3 years ago, it took us 4 weeks to do it. So everything's faster and cleaner in 2017. And again, these can be printed at any time by your laboratory or by yourself, depending on how much time you want to put into it. Another typical digital overlay, and the best part about these is once you get good at this, this will probably take you about, I don't know, maybe about a day working with all the professionals in the system to learn it. Once you learn it, you take a screenshot of that, you put it on your letterhead, and when you're presenting it to the patient like this, it becomes very valuable when they walk away with this treatment plan and this options and exactly what you discussed at the treatment presentation. So this is what we're going to do, and this is what we've shown you. They take this back, and it becomes very valuable. We give them the fee for the procedure, and they know exactly what's happening with their mouth. This would be a typical incorrect planning. Sometimes I'll get x-rays from doctors and say, "Doc, help me with this planning." This is a poor plan because you see the implant's going for a screw retain restoration when it really should be a cement restoration, and the angle should be this way. They did beautiful bone augmentation here, but they're planning it the wrong way. So I say to them, hey, listen, you're off on this angle. Put your implant this way. You shouldn't have a short implant in this case. You should have the longest implant you can, maybe a 13, to get some good primary stability, but it's going to be a cementable case. So trying to plan for screw retain, you're going to get in trouble. Plan for what the patient is best for the patient, and you'll have a much better result. This is the same patient when they sent me the whole case with the DSD 3D motivational photos and scans intraoral. We got the design back from the laboratory, and we see, what did we see here? We tell the patient, look, to get your perfect smile in the right position, you're going to be missing a lot of tissue. So she needs a bone graft and a tissue graft to get this to look the right way, that the tissue here is going to be aesthetic and healthy. That's how much tissue she's missing. When I show her this presentation, she understands it. If I tell her, she doesn't really get it if you just talk to patients. When you show them, it's very different. So showing her the different files and showing her where she is and how much she's lost becomes very real to them in a digital platform. That this is where the tissue you lost. You need to grow the bone down, grow the tissue so we can get you the perfect position of your teeth. And you can see occlusal analysis. I show her, her bite is in the wrong position. I can't even get a tooth in here. It's impossible unless I restore the vertical. So that makes them understand that it's not just the anterior teeth. It could be also the posterior teeth extruding out into the position that now I have to either reposition this tooth or do some kind of orthodontics or do some kind of vertical change to get this to fit. So again, showing them clinically what they have in a digital platform is a lot easier to understand. And we did a full workup on this with the DSD protocol and Germ Dental Labs. And then slowly the case got approved. It took her a while to get her finances together. But at least she knew that we knew exactly where we were going, to the millimeter, where our implant's going to be, where the bone's going to be. And this is how DSD actually became also a virtual lab with the technology of implants, and not just smile design, but implants and abutments. It was a really good merger of information about 2 years ago. So what's new in terms of the ideas and the new ideas that we are discussing in terms of anterior? The surrounding bone level, when should we put immediate, when not to put immediate, occlusal analysis of each patient, and when can we simultaneously treat patients with implant and veneers. In terms of the protocol, diagnosis for single tooth implants, radiograph, CT scan evaluation, have the provisional ready at the time of surgery. What kind of provisional should we have ready? Well, we usually have an immediate fixed provisional, if we can get it, or if we're not going to get primary stability, we're going to ask for a bonded provisional. So we either have a bonded provisional or an immediate place provisional at the time of surgery in terms of the anterior, or maybe an Essex retainer. We don't use removable other than Essex retainer. Proper size and implant placement of the aesthetic result, we're going to base it on the CEJ. Where the CEJ is, 4 millimeters below. You're going to find that number 4 millimeters being very crucial in our design. In combination of ceramic cases as well. We'll show you some combination cases. So we're going to do our anterior protocol, merge the files together, do our scan, do our CT scan, merge the files as we said before. We'll take our digital impressions at the time of surgery, and we'll take our digital impressions at the time before we extract the tooth. You're going to see us taking impressions before we hold on. We have to go back. I'm stopping this for a second. Okay. Start back at slide 63. Take our digital impressions preoperatively, especially to capture the anatomy of the tooth. So it doesn't matter which scanner you have, we're going to still do it the same way. All these scanners have been used in our clinics, some better than others, but right now we're basically using Trio's implant scan. So all these anterior restorations were done with scan technology and mill technology. Well, let's take a look at the benefits. Clinical procedures are faster, fewer patient appointments, increase the patient experience. That becomes very valuable. And then maintaining the soft tissue, maintaining the bone tissue, not having to recreate it. Let's look at the literature. The flapless design in 2009 from Block. 2011, the intact socket, trying to maintain an intact socket with Liglunder Akimoto. In 2012, the position of the implants became important in terms of the connective tissue graft. The GD talked about the diameter of the implant in 2012. In 2014, Lee and Fiorellini talked about the provisional being important. Tarnar Chu-Salama talked about the bone grafting, where to put the bone grafting, the connective tissue with Gardopoli in 2014. And now in 2017, our digital provisional, which really showed to be the fastest and easiest to duplicate in terms of anterior aesthetic expectation. So if we look at Block's article in 2009, he talked about the provisional being important. He used an acrylic and titanium provisional to scallop the tissue. So that was the first kind of starting of, well, it was started back in 1994 with Peter Worley. But a lot of the papers started showing the beautiful anatomy and the preservation of his tissue from the provisional phase. And most of the great results had to do with the buccal plate being present and the provisional at the time of surgery. And this is one of ours where we can get the beautiful design, preserving the buccal tissue at the time of placement and being able to do that. So let's look at, again, some more articles that were written. 2009, place the implant from a CT scan position. You can see here the buccal plate's very clear. There's no other way to look at and evaluate the buccal plate except for a CT scan. Route's paper is beautiful. He also shows the 4 millimeter number. From CEJ to buccal plate, 4 millimeter on the average. That's a key number. You want to place our implant 4 millimeters below the CEJ, which is just about at the crest of the buccal plate. But as you see here, some of the buccal plates are 0.88 millimeter. It's a tiny little buccal plate. So it's understanding that buccal plate is very small. It's hard to see it, and it's really hard to probe it. So without the CT scan, it's really hard to manage. Kahn's paper in 2010, 2013 graphically showed that how important it was to measure the buccal plate and understand the thickness of the biotype to get that anterior aesthetic result that we all want. The DG's paper talked about the lingual placement of the implant and adding some grafting on the buccal, but engaging that lingual plate here, very important, adding the buccal grafting material, but preserving that beautiful buccal plate and the marginal tissue. In Chu Salama paper with Dennis Turner talked about the different groups and how the provisional was so key to develop the group 4. Group 4 developed their tissue the best because the buccal plate was present. And then recently, Chu Hockman and Turner talked about the shells to preserve that area. So they place the shells at time of surgery, create their emergence profile with the provisional, and that holds the tissue in position. But you see here, the measurement here down into the sulcus is 4 millimeters. So 4 millimeters becomes a crucial number. So in our paper, what we discussed was the placement of the implant using a CAD-CAM design and using a crown root form technique from provisional to final restoration, which I will show you in a bit. And that was the kind of results that we'll be able to get by preserving that buccal plate using a CAD-CAM provisional. So the question is, should all patients replace their tooth with an implant? Is a ceramic bridge better? Sometimes aesthetics becomes a factor if they don't have a buccal plate. The tissue's not thick enough. So some people just can't afford to have all these elaborate procedures, and they will go with a ceramic bridge. And that's okay as well. But when we are thinking implants, we're thinking of the digital approach. Digital approach means CBCT scan on every case, merge the files, do a virtual wax up approved by the doctor, mail the surgical guide, put the provisional if necessary, if you can, and then place the implant in the proper position. Scan the impression if the tissue has not been disturbed. So sometimes we'll scan at the time of placement. That's a critical point. Digital workflow status today. CT scan, place the implant, scan if possible. Put the scan body on, scan if possible. Immediate provisional if we can. That's only 20% of the time. Most of the time we're bonding our provisionals. Stage 2, deliver the abutment, because we've scanned it at stage 1. And then based on the existing anatomy, we can create a beautiful abutment. If we didn't do an immediate provisional the first stage 1, then we're going to scan and place the scan body at stage 2, scan for the final restoration, and then deliver the final crown. This becomes the real standard digital workflow that really works today. We want to get tissue that works like that. But again, the only way to see this buccal plate is through the CT scan. What is the etiology of the tooth that's missing? Is it periodontal? Is it trauma? Is it non-vital infection? Is it anodontia? So if we know the aesthetic expectation of all these, that the periodontal is the worst aesthetic expectation, non-vital infected tooth may or may not have a buccal plate. The endodontia usually has very thick tissue, and you're going to get a great aesthetic result. And usually the trauma non-vital tooth with no infection has the best buccal plate. So we find that to be that really valuable. The radiograph analysis is going to show you a two-dimensional design. Soft tissue analysis is going to show you what's happening with the soft tissue. But the real analysis has to do with the buccal plate analysis, right? Looking at the tissue through the CT scans. That's what's going to give you the real analysis of the buccal plate and if the pink tissue is going to happen. The only way to do that is with the CT scan. We do all these evaluations and we try to predict where to put the implant. Again, looking at all the different papers, 4 millimeters seems to be the better number. Smaller diameter, not the 5 millimeter diameter for a large central, but more the 4 millimeter diameter and a 4 millimeter depth of tissue. Planning, placement, provisional, impression, final abutment, final restoration, occlusion. This is just the workflow. We want to capture the bone, capture the root with the CT scan 4 millimeters deep. We want to print the surgical guide from these files, capture the anatomy of the tooth and the root together, and then merge the files. We want to plan for surgical guide, capture the anatomy of the tooth, and then use the guided implant surgery and confirm the apical position, especially with multiple implants. Bone fill if necessary, bone augmentation if necessary, soft tissue augmentation. If this happens, we get the periodontist involved, or the surgeon. If you're doing the surgery yourself, then you'll be able to do it together. Let's just go through this case, anterior digital workflow. Aesthetic expectations are poor because of periodontal loss, so we're going to probably have some spaces in here. We do the CBCT analysis, and we realize that there's a lot of bone loss there, so the aesthetic expectation is questionable. We can't do immediate restoration, so we're going to do a bondable, fixed, bonded restoration as a provisional, composite reinforced. You can see here the tissue design after surgery, bonding the provisional, and then over time you see the tissue really heals nicely because it's a nice ceramic or composite feel. Once we get into stage 2, we'll go ahead and access that. You see the bonded provisional here. It's slowly detached. You get a nice tissue response there. We're going to uncover at stage 2 and sometimes create the tissue. The tissue may take 3 to 4, 6 weeks, depends on what? Well, it depends on the patient's healing. So everybody really heals differently. We'll do a digital impression of the tissue, captured it. This is with a Lava COS. You see this is a scan body. You can capture that tissue digitally. You can marginate it. Again, the capture of that tissue digitally right there. Again, right here, you can see the outline of the tissue very clearly. Develop it, we mill it, and it's printed for the original files and from the final impression. So from the original CT scan and from the final impression, they merge all those files together to create the final abutment. The final abutment is tested. Accuracy, quality, quantity is done by the dentist. And the anatomy of that tooth is looked at on the digital file. In this particular case, we made 2 of them. You look at CAD-CAM abutment A, CAD-CAM abutment B, very different, right? So that's going to push the tissue. We don't want to do that. So I purposely did that for educational purposes, but you see the smaller one uses the tissue and lets the tissue fall a lot better than the wider one. Once we have that, we're going to scan it. Again, let the tissue mature. And we're going to use this mathematical procedure. This is more for the technician. We published this in 2014, and this basically said that the depth of the tissue, let's assume it's 3 or 4 millimeters, when that abutment is extended out, this is the mathematical formula, which I really have no idea what this means. What I do know is that when this abutment comes out of that tissue, it creates an angle. And if that angle is a certain amount, you see a 4 millimeter depth tissue with a 30-degree angle has a 0.5 millimeter change of tissue. That's the change in here. May not be critical for posterior, but that's critical for anterior. When we change the angle to 49 degrees, if they push this out too far, you get a 1.4 millimeter change in that tissue. That's very critical in the anterior. So by understanding the mathematics of this, the depth of the tissue, the angle of that abutment circumferentially will change that tissue. We want to minimize that. So we want to minimize angle A every time we have an abutment. So again, here you see a 3.4 millimeter depth with a 61 degree change in abutment all the way out here will cause a 1.8 millimeter change in tissue. In this particular case, we want the tissue to go up, so we purposely increase the angle to get that tissue to move up. Most of the time, we want to keep it low. And you see we moved the implant from where it was to here. We moved 1.8 millimeters of that tissue based on the formula. And we got a really nice result on an 89-year-old patient. Scanned it. This is 7 years post-op. You see the tissue there is healthy. because we actually pushed the tissue out. The implant was placed inward. So all these things are documented for the technician to really help us. All the implant companies have scan bodies, so you can look up your implant that you're using and look at just customize the scan body if you need to and merge the original files from a CT scan. Again, a typical scan, placement, planning of it. Here's the hand steel unit. We're going to go ahead, place the implant where we want it, 4 millimeters from the CEJ. Use the scanning technology, scan the scan body, send the file to the laboratory, evaluate it ourselves. This is our typical evaluation, the clearance, the position, the gingival length. This is what I'm doing on a daily basis, is making sure this angle is correct, not pushing the tissue too much on the vertical. See, we want this tissue to be right at that 0.5 millimeters below. And you can see the distal has been brought out to push the tissue, and the mesial has been pushed out, but the distal has not been pushed out. So each side is different depending on where the implant was placed. And that allows the tissue to look like that. So the angle of the abutment directly relates to where the tissue is going to wind up. You can't just use stock abutments, and you can't even just use stock CAD-CAM abutments. You want to be able to quantify it from the formula. And that'll give us results like this, where the tissue is maintained. You can't see the difference between the implant tissue and the natural tissue. And again, whether it's screw retained or cement retained depends on where the bone's going to be. So don't get locked into one type. CAD-CAM crown, milled, printed, pressed, all those work. Check the contacts in all position, centric relation, centric occlusion, right working, left working, and protrusive. Different materials right now. We have milled materials. We have aesthetic materials. They're very translucent. Here's a typical fractured tooth. Fractured teeth usually have a great buccal plate. So when we extract this tooth, we know we have plenty of bone to go ahead and place the implant. We'll place it immediately. Use a provisional. Use a scan body. Scan it with any scanner you want. Doesn't matter which scanner you use. So you're going to get a great result if you have a good laboratory. We're going to use the Finding Z formula. Look at the angle that we're creating here. It's a very slow angle. We don't want to push the tissue out, right? So here you find the angle changes is very minimal. The changing of the Z. So here we've only changed the angle 17 degrees, which gives us a change of the Z of only 0.5 millimeters. So the formula really helps the technicians work it out. We get a perfect abutment. We place the abutment, put a provisional there. We let the tissue scallop. That takes at least 8 weeks sometimes 4 weeks, sometimes 8 weeks, depending on the patients, how they stipple in. Place the abutment, let this tissue heal. Put another provisional on here. Let it wait till that all gets nice and stippled, and then we take our digital impression. We do our CAD-CAM abutment in here, our CAD-CAM crown. We polish it in the mouth, make sure we have the right contour, and then we glaze and stain, and we get a beautiful ceramic Vita block completed in 2010. That's 7 years old. Sometimes we have complications. Patient the implant was placed in the wrong position. The patient was referred to us, and we get things that look like this. This becomes a surgical nightmare. The surgeon gets in. We bury the implant with a very flat healing abutment, and he does a soft tissue graft, connective tissue graft. This is Dr. Elchar, who published a paper on this. You see how the healing's going, 5 months. We have a fixed provisional, basically a pontic. You see how much tissue he's been able to regain there. We put a very, very, very small customized abutment there. The tissue is maintained. 6 months later, we wait, and then we finalize in about 8 months. So you see the tissue went from here to here if we have a complicated situation. But that's all done from fixing the actual tissue with connective tissue grafting. So to summarize our anterior implant aesthetics, we want to look at types of implants, types of loss of tooth. Root fractures have the least amount of change. Perio and root resorption have the greatest amount of change based on Ross's paper. This is a great paper, 2015, on the groups. Minimal change if they had the buccal plate, and the provisional was done. Buccal plate preservation, Sands paper in 2009. And then using these customized healing abutments to get beautiful profiles at stage one, flapless surgery. Kahn's paper in 2013 about the position of the implant. Tarnow's paper in 2014 about the group 4. Gingival graft a graft, a small bone graft, and the provisional gave them the best result. We're going to copy that technology with our dual zone, bone zone, tissue zone concept 2012. We're going to copy all that, and we're going to take it to a digital platform. So here's how we did it. Here's the patient. This tooth is going to be extracted. So before we extract the tooth, we look at our measurements, 5.3 interproximal, which is going to give us a good relationship of the bone tissue and do not get a recession, 3.1 on the distal. We're going to capture the bone 4 millimeters deep with the CT scan. We're going to capture the tooth with our scanner, right? We're going to scan the tooth, scan the root. Those two files are merged together. Capture the anatomy of the tooth, capture the anatomy of the root. Together, we're going to plan our immediate placement, whether it's screw retainer or cement retainer, depends on the angle. So here's our pre-op scan. Pre-extraction, pre-op scan 1 week before extraction. Everything's done in the laboratory from this point. It's merged, the files are merged together. The CT scan and the intraoral scan are merged together to give us a perfect profile of the anatomy of the tooth. How many millimeters deep? How many millimeters deep are we looking? 4 millimeters deep. 4 millimeters deep. Here's the CEJ, 4 millimeters deep. That's where the implant's going to go. The angle is going to be this way, so it's going to be probably screw retained. Here's the merging of the file. Here's the outline that the laboratory does. And what do? They print us a tooth root form provisional. A tooth root form provisional. Copying the root of that patient. Copying the root of that patient and showing us the angle of placement. Here's the surgical guide. Here's the placement of the implant. Here's the bone around it. The patient's done by the surgeon. Patient comes right to me, flapless surgery. This is about 20 minutes after extraction. I place a temporary cylinder. Doesn't matter what implant you're using. This happens to be a Biomet 3i. Here's the root form. Copied the tooth. The root has been copied. The tooth has been copied. A B1 shade PMMA provisional. I section the temporary cylinder. I polish it. I lay it over the tooth. I put a little plastic tube, so none of the Luxatemp. The Luxatemp is going to be syringed into this. All the Luxatemp gets syringed into that. I'm going to hold it in place. Let the Luxatemp set. This is the X-ray after it sets. CEJ to root 4 millimeters deep. 3 is not enough. 5 may be too much, but definitely 4 is the right number. 5 won't hurt you, but 4 it's got to be. So here you see again, the implant's placed here, 4 millimeters from the CEJ. I use some flowable composite to polish it up so it's nice and clean. This is Steve Chu's technique, exactly copied from Steve Chu. But the difference is the provisional was already made. I didn't have to recreate it. Here's the access hole. Closed, out of occlusion, no contacts, nothing, so there's no movement. Tell the patient do not touch with their tongue, do not eat with it, do not look at it, do not do anything with it, have no anything touching it. Extraction, placement, bone graft, provisional is out of occlusion. This is 75 minutes after extraction. I'll show you 24 hours. So the only difference, this is a key factor. Natural teeth have a natural convex contour. The only change I made on that provisional was to make that change concave, right there on the facial, just to let the tissue fall back. So the tissue and the bone really never see it. She takes a Facebook picture, puts it on Facebook before and after, which showed us exactly what she looks like, so she's not embarrassed about it. 7 days later, you see the tissue is actually coming down. It's actually lower than the other tooth with the provisional. This provisional here is 30 days later. It's in the right position because we basically extracted the tooth and put back the anatomy that was there, copied and pasted from the original tooth. This is 3 months. This is 4 months. The tissue is actually coming down. Hasn't been touched. We take it off at the 4-month position, slowly take it out, and that's the way the tissue looks. Has not been developed yet. It's not 100% healed. We take our final impression with a scan again. We do our scan body, take our final impression. And what you see here is composite laid over into the tissue. And we go back there a second. I want to make a point of that. This is composite flowed into the position to keep the anatomy of that tissue exactly where it is. We want to copy that tissue onto the Trio scan. We put back the provisional, we use our formula, and we use all the information preoperatively and now postoperatively to design a perfect CAD-CAM titanium-based zirconia abutment. And that is the way we're going to preserve that tissue. We've copied the anatomy of that tooth digitally to preserve the mid-buccal facial tissue. That's the final abutment before insertion. We let that heal, make a provisional on that, and then we design it. And we see the position, and this is the whole exact protocol with the abutment, the root form provisional. The provisional place, the new scan at stage 2, the final healing of the tissue, the abutment design, the tooth design in Emacs, radiograph of the final restoration, and the final restoration placed that day. And over the course of 2 months, you see the final healing of that patient and the side view of the healing of the stipple tissue. So we really see that by copying the tissue of the bone from the pre-scan and copying the position of the tooth, you can really replicate exactly anterior teeth, posterior teeth, multiple teeth by using the CT scans, merging the file with the teeth that are there before extraction. That's really the key point, is merging the patient's anatomy of the root below the CEJ 4 millimeters and capturing that at stage 1 to really get the perfect anatomy and contour of the tooth. For those of you who are thinking about and wondering about full arches, I just kind of threw this in there just to show you that's the final result 2 years later. That full arch scanning is available. It's accurate if it's done the right way. And we've done over 80 arches of implants and teeth. I'm sorry, 125. 80 were implants and another 45 of teeth. Where we can actually design the abutments, use the merging of the files of the provisional to really get the zirconia frames in the right position, so we're not trying things in. We don't want to be in a trying position. We really want to know where we're going. In this case, was done in less than 5 visits between scan and completion, based on all the digital files. So you see the design features of the anatomical position, the BIS bake, and then the final insert. From scan to finish, it was 5 visits on a full arch. So it is available. The restoring vertical dimensions, we're using reference points and all these things, implants, aesthetics, and occlusion, is really working with our digital platforms very efficiently. We have multiple day courses coming up. We have a 4-day course in October. If you go to our website, fmrnyc.com, you'll be able to see that. But I want to, again, reiterate that digital technology without fundamental principles is wasting a lot of time of software. So understanding inclusion and functional aesthetic relationship is important. My phone number is here. You can text me or email me, Facebook, Instagram, Instagram New York Smile Institute. Any information I could help you with, buy a scanner, use a scanner, laboratories, some materials. More than happy to help you out in any way I can. And the mentors and the people that have shoulders I stand on have helped me throughout my career, and I want to always acknowledge them and many, many years of gratitude. Thank you for your time. I hope this was valuable for you. The reality of digital dentistry continues, and we are here to help you in any way we can digitally. The future will be digital technology, I guarantee it. Thank you very much.